I'm John Clemo. I'm Chief Executive at Community Action Norfolk. Welcome to this session of the 2020 Norfolk VCSE Conference. It's hosted jointly by Community Action Norfolk and Voluntary Norfolk. And this session is focusing on the direction of health and social care. Health and social care is one of the key areas of both interest and activity for many VCSE organisations. So it felt a really important part of the conference we're running this week. I'm delighted to be joined by Melanie Craig, who is Chief Officer at NHS Norfolk and Waveney CCG, and also the Executive Lead for Norfolk and Waveney Health and Care Partnership, and James Bullion, Executive Director of Adult Social Services at Norfolk County Council, as well as President of ADAS, the Association of Directors of Social Services. In terms of format for this session, we've asked Melanie and James just to provide a short bit of presentation, which I gather Melanie is going to guide us through. And then in advance of this session, we asked colleagues to submit questions, which I have attempted to kind of craft into a little bit of conversation, which we will naturally lead out of the presentation. So Tasha, if we can pull up some slides, and I will hand over to Melanie.
Thanks so much, John, and thanks, Tasha, and hope all of you are having a good day, and it's really lovely to be here with you all. And thank you so much for joining this session and for inviting James and I to present to a little bit and hopefully answer your questions. We've been given very strict instructions to stick to 10 minutes so that there is maximum time for questions. So we've decided that I will take us through these slides. I would have loved, I can see there, I think there's what, over 40 people on the conference. I would have loved the opportunity to just go around and see who's here and say hello. I can see some familiar names that I recognise from when we were in buildings, particularly. I recognise Sue from the Motor Neuron Disease Trust, and also Nigel Bolero, who worked with us just very recently on the green social prescribing bid that we made to NHS England, and many more familiar names. So it's really nice to kind of see you virtually a bit anyway. I'm going to just take us through a little bit of a presentation. I think the question we've been asked to answer was just, really some reflections on the last 8 months or so, and thinking about the future and how we build back up, because some things will never be the same again, and some things we thought we could never achieve, we have achieved, and there'll be some things we firmly don't want to carry on with in the future as well, such as socially distancing, wearing masks, and all of that. But can I just start by saying, a hugely heartfelt thank you to all of you and to your colleagues in the organisations that you're representing and working with. I think the impact of the voluntary sector in the first wave and the subsequent pandemic has just been really hugely well received and made such a difference. And I'm so grateful for all of the immense efforts that you and your colleagues have achieved, working in extraordinarily challenging conditions. And this leads me on to my first slide. I don't know if it's exactly 8 months and 12 days, but thereabouts. And I think whether you work whichever part of the system you work in, the NHS, social care, VCSE, it's really been just such an incredible achievement how people have come together really selflessly and worked together as a single team, which has been hugely appreciated. And we have achieved a number of successes, certainly. And the voluntary sector as well has been, I know, faced some very hard times as well, and has been hugely flexible. So thank you to all of you for everything that you've been doing. I don't know if it's exactly 8 months and 12 days, but thereabouts. So moving on, please, Tasha, to the next slide. I think one of the things I was asked to talk about and thinking about the future was, they're very much that concept of working together selflessly, not for the organisation, but very much for the communities and for the population as a single team. And that's in essence the spirit absolutely behind an integrated care system. And you'll be familiar with the concept at the moment that Norfolk is a sustainability and transformation partnership, which is such jargon. Really, but is very much of the last 4 years. We've been working as a great, effectively trying to work as a single team. Now, the integrated care system is effectively a designation, no more than that. There's no other prize that comes with being an ICS other than designated as an ICS. It's a reflection on our achievements and efforts and willingness to work together as a single team, really is how I best think of it myself. And so the acronym is ICS. And before March, we as in Norfolk and Waveney were making efforts to accelerate our progress on that journey of being an STP to an ICS. And that's national, and that's NHS policy. Now, all of that work very much paused over the probably March through to the end of June period, but then picked up again. And I think picked up again with a renewed vigour nationally and locally, because I certainly appreciated and saw how the collaboration and cooperation that we worked with in that spirit during those first few months, it was very rewarding to be part of, and we achieved a huge amount by working together. And so I think, that was very much called out by NHS England, how we'd worked together as a system, and therefore we were put forward to express an interest in being designated in an integrated care system in the autumn window. And on to the next slide, please. So really, what are the priorities for Norfolk and Waveney? Why would we create that? And these are our three priorities. The three priorities that many people within the system got their heads together and came up with this. And hopefully these will, make sense to you. We want to improve the lives of everybody, reducing inequalities, unjustified differences in care, wherever you live in Norfolk and Waveney, and to provide the very best health services and to get the best value for the Norfolk pound. And by becoming an integrated care system, that does help us. It brings in not just the NHS, but also social care, county council, districts, and very importantly, VCSE. So on to the next slide, please. Many of you might be familiar with this. It's not a Norfolk slide, it's a national slide, but these are the three layers of an integrated care system according to the national policy. And it enables us to plan on different footprints. So at a very small local community area, a neighbourhood, which is a primary care network, and we have 17 primary care networks across the whole of Norfolk and Waveney. It can be an area like, for example, Great Yarmouth or North Norfolk. So North Norfolk has 4 primary care networks, but it enables us to really focus on the particular needs of the population on a very small geography and plan for their needs on that footprint. Then we have place, around 200,000 population. So Norwich is a place, and so forth across Norfolk and Waveney. And then system level, which is Norfolk and Waveney, just over 1 million. So those are the 3 nationally recognised levels in an integrated care system. And it just enables us to be clear about which decisions need to be made at different levels. And on to the next slide, please. I'm just keeping an eye on my watch. A locality focus, certainly during the last 8 months, we've really, I think the pandemic has underlined the need for integration at a more local level as well. And certainly some of the ways that the county council, district councils have worked with voluntary sector have really supported local communities. And on to the next slide, please. I won't dwell on this one. This just again sets out we're happy to share these slides afterwards if you haven't got them already, but this just sets out some of the emerging functions and purpose, and some of those you may resonate with some of those functions. This has been produced by the King's Fund, but I find it particularly helpful to remind me about what's important in an integrated care system and why we would bother. On to the next slide, please. Many of you may be aware that part of the governance for an integrated care system is to have a partnership board, and this would be a board that at this stage doesn't have any designated decision-making power, but certainly the view would be for it to bring together all partners, including voluntary sector, and reach decisions, reach a consensus rather than necessarily having formal ratification for the decision-making. And the health and wellbeing boards, so that's for Suffolk and for Norfolk, would hold the ICS Partnership Board to account. So you get the local democratic accountability. And that's how it is set up. Just moving on, please, to the next slide. I've included a slide here which sets out proposed membership of our ICS Partnership Board in Norfolk. And you'll see there is a place on this board which we have deliberately kept quite small for the voluntary sector assembly, and a representative, the chair or another nominated representative from the VCSE assembly would be invited to be a member of the partnership board. Now, the caveat to this is that we are proceeding at the moment working underneath the current legislation. We do know, as I'm sure many of you are also aware, that we're expecting legislation to change potentially. Don't know exactly what it might say, but we expect that there may be a move before April 22 to designate ICS's integrated care systems on a more formal legal footing, and that might change the nature of what we do. It might also come with more of a prescribed membership of the partnership board. Don't know yet, but I wanted to just mention that. At the moment, we're working under the legislation that we currently have, and there is flexibility for us to design a partnership board as we see fit. So this is the result of much work across Norfolk over the last 6 months. So come to the next slide, please. Been really pleased to see how despite all of the difficulties and major operational challenges and distractions we've all had to deal with over the last 6 months, that the work around the VCSE assembly has also accelerated, and I'm really pleased that we will have an assembly of the VCSE to bring together all of those different bodies and to, again, just strengthen the voice, I think, and increase the influence and participation on the partnership board. To the next slide, please. So key areas I think are important for us to develop are certainly that sense of an equal partnership. This is always a difficulty, certainly from the NHS perspective. I would suggest James may have other thoughts on this, but there is a direct line of accountability from the NHS right up to the Secretary of State. That there are some things where we're not given permission to be as flexible as we would might want to, but notwithstanding that, that I feel I would really like us to do more to develop that sense of an equal partnership involving the VCSE in Norfolk and Waveney. Ensuring that the model is more sustainable. I hear and I understand and listen to the concerns raised by VCSE about funding being short-term and having a more sustainable resourcing model. I think is really important. That would be important for the VCSE Assembly and the ICS Partnership Board to look at. Again, thinking about how digitalisation can be integrated across Norfolk and Waveney. We're now finally getting all of the NHS onto the same digital soft footprint infrastructure, which you might have thought that we already had in the first place, certainly didn't. And to try and find a way to integrate that with VCSE would be wonderful. and again data sharing. And this is a really difficult area where even within the NHS it's sometimes difficult to share information, let alone with social care, and then again with VCSE. But it's certainly, I think I would like to hold that as an aspiration, certainly. And so I think many more slides now. I mean, certainly again, just moving on then, having identifying consistent set of tools that both sectors can recognise, so that when there are opportunities, we immediately recognise, acknowledge and have mandated tools that we can use to bring to gather evidence and to evaluate pilots. And pilots, wouldn't that be wonderful if we moved away from pilots and just moved into evidence-based implementation? And commissioning, again, having much more of a joint approach for health and social care framework for VCSE commissioning, I hope would be really welcomed by the sector. And moving on, please.
I think that might be your final
That's the last
slide.
one. Yeah, thank you. So thank you very much, John. I hope we didn't go over too much, and I'm really keen to hear from people, and James might want to make other comments too.
James, I will give you first comment before I go on to the questions, and Tasha, I guess if we could just drop the presentation down.
Thank you, John, and thanks, Melanie, for that introduction. I hope I'm off mute. I am. Yes, I'm usually for me. So the only thing I wanted to add to what Melanie has said is that part of, as we move forward into the ICS, we're very excited to do that and to have that local agency to take a further integrated approach. The only comment I would add, other than to acknowledge the role of the VCS in our pandemic response and the impact of the pandemic on people, my other comment would be, looking forward from my perspective in social care and in public health, there's an expectation of further government reform that might enable us to take more into this integrated approach from a social care perspective. Not just government reform about the means test for social care, but taking stock of the Care Act 5 years in, and hopefully providing some additional resources to give us some ability to invest in prevention, which is the ambition, of course, of the ICS too. Thank you.
Great. Thank you very much. So over to the questions, and sector colleagues have not disappointed in terms of the variety of topics as befits the sector. But just to kind of kick off with, we've been doing some interviews with VCSE sector leaders as part of this, and we've been asking them 3 questions that some of you will recognise from the kind of the signs of safety kind of framework. But kind of, what are you most proud of? Where are your biggest kind of concerns, and where's your focus going to be over the next 6 months? So firstly, Melanie, if we start with you, I'd just be interested in your thoughts around those 3 questions.
Yeah, great questions. Thanks, John. So what am I most proud of? Can you just say the
most proud of, your biggest area of concerns, and where your focus is going to be over the next 6 months?
Okay, right. What I'm most proud of, I am proud of how back in March we absolutely moved like the clappers. We really did. And you know, everybody, including myself and so many colleagues, were just working, you know, silly hours, and it was just all completely new and unprecedented. And we absolutely will have made mistakes. We did make mistakes. It was new. But the spirit and cooperation, I couldn't have asked for anything more from all of my colleagues who just did whatever was needed across the whole of the NHS. People just were totally selfless. And I know that some of the things that we did made a difference to transmission rates and how we were able to look after people. So I'm really proud of that first wave, notwithstanding that I know, you know, we were dealing with things for the first time, and we will have absolutely made mistakes. In terms of what I'm most worried about, is that the next question, yep. John? What I'm most worried about, I think now, is really the next 2 questions. I could give the answer for either one of them. And what am I most worried about, and where's my focus going to be? So interchange them as you will. I think I'm most worried about just the areas that I think we're now looking back, and of course we're reflecting on the impact on people from areas of the community that had very little. The economic impact of this pandemic has just been immeasurable, and the consequences to people, on people's lives, that just of people who were of all walks of life, people who had very little, people who had a lot. People have just, massively, their lives have been turned upside down, and the impact on their health and well-being and their mental health. And I think particularly, that's what I'm most worried about, really. Worried about children and young people's mental health now, which has just seemed to become, sadly, a real norm, that all young people, or many young people anyway, are having really very, very troubled mental health experiences. And I say that I've got two daughters myself who are older teenagers, and their friendship groups and themselves. This has been a hugely challenging period for families, and how we then pick up the pieces of that as society and as a health and care sector, I think, is what I'm most worried about. That's not to say that we can't make improvements. Of course we can, and do things differently, but that's something that really troubles me. And then where is my focus going to be over these next, let's say 6 months? Probably my answer 2 weeks ago might have been different than what it is right now. We're absolutely just trying to execute the biggest logistical program ever with the COVID vaccination program, which is massive, on top of the flu vac program and everything else. And I guess, the focus is on just keeping everyone going when people are shattered, haven't really had much of a break, are now, facing maybe not quite the same level of public support and feeling valued as they had in that first wave, but really just trying to continue to look after people and keep them going and keep them motivated, because, there is so much at stake now over these next 6 months.
Thank you. James, you've had some thinking time.
I have. I'm grateful for that. But it's actually a very similar list to what Melanie has described, really. I mean, I'm very proud of the work that we did together on shielded people and the response, which was community sector and statutory. The work we did on rough sleeping has demonstrated to us that, things appear to be hard, but actually, when we agree on something, we can really move and act. And why shouldn't we do that, all the time? I'm proud of the way that we've kept a balance between safeguarding and keeping people safe. By the same token, I'm concerned about the impact of isolation actually on people in care settings. And I'm very proud, I think, of the way that the council stood up to try and support the care market. So we paid out some 32 millions of one-off money that government has provided us with, and provided PPE and things like that. And this has been so rapid, we've forgotten about some of those battles actually that were really battles in the first stage of this pandemic. So I'm proud actually, in the sense that we probably put local authorities on the map a bit more, hopefully to government that's now listening, to say, doing local and getting local authorities and health services to work together with the community might not be a bad answer. My worries are today. I'm quite worried about the fragility of the social care market and its ability to respond now because of occupancy issues, cost and staffing issues. I'm very worried about staff turning away from social care because of the trauma of this pandemic and the wages issues and the turnover issues. And I am worried about the safety and safeguarding of relatively closed situations, because that's what's still happening. And finally, I'm concerned about carers and the impact of informal family carers and the strain and the stress on them now after 6-7 months of that. And then focus of attention, like Melanie, really, trying to make sure we don't forget about winter and flu and responding to the ordinary stuff that occurs this time of year. Worried about the impacts of the asks on the social care sector around testing and bringing people together. We mustn't be complacent. There's a really strong link between community outbreaks and vulnerable people being affected by the pandemic, and vaccines won't be here for 5-6 months really. in terms of their impact, we've just got to make sure we get the balance right, I think. And that's, that will take up all of our time actually for the next 6 to 9 months. And I hope we don't see any casualties, but I think we need to be realistic about that.
Thanks. You. So the first block of questions I kind of have really fall under the theme of kind of prevention. But before we kind of pick those up, Melanie, I just wanted to go back to one of your slides in your presentation. What seems like a millennia ago, at the start of the year, we had the local version of the long-term plan, and that listed the priorities for the system essentially being prevention, integration, and workforce. And I noticed on your slide about the ICS, it had a fractionally different list, which was inequalities, integration, and best value. And I just wanted to ask you, is that a strategic shift, or is that an accident of us juggling a lot of different documents with very similar names?
I'm glad you've called that out, John, because I was expecting that third. I'm very familiar with these slide sets, and sometimes don't even look at them too closely because I can kind of talk to them without, use these slides a lot. And I don't know where that good value came in from. It should have been about workforce, about making Norfolk the best place to live and work, and so that we can attract as many staff as possible because of our geography as well. It can be, this is one of our limiting factors in Norfolk. When we are able to get people to come to Norfolk, they stay. But actually, this is a problem. So, John, there's been no change in that. And thank you for giving me the opportunity to explain that, because it is very much absolutely our third priority. Actually, getting the most out of the Norfolk pound is serious and is significant as well. But that, that maybe I can come back to you with another slide on that so that you could circulate it to the group, because it was 3 priorities in the long-term plan and they still stand.
And just that difference between addressing inequalities versus supporting prevention, which I think some sector colleagues would see as a slightly different change in emphasis.
Yeah,
I don't think this has been. I think this is the editing of the slide rather than anything more to read into it than that, John.
Right. So sector colleagues can rest assured that prevention, both with promoting independence in adults and within our HS colleagues, is front and centre in that space. It's obviously something prevention we've talked about for a kind of number of years now. So I guess the first question is, how much progress do you think we've kind of made in the last 5 years on that sort of prevention agenda? James, I will bring you in because Melanie got more thinking time.
Yeah, I'll start off. But in starting off, I also want to make the point. I mean, Melanie's quite right. The priorities haven't changed, but the pandemic has exposed inequality in a way that just simply was being ignored by the system. So I do think that as part of our prevention response, we have got to really focus on inequalities, and the public health data and all of the impacts on Black and minority ethnic people is showing that you can't get prevention right unless you start addressing inequalities. So I do think it's the same, but it's an aspect of prevention that perhaps we need to give more emphasis for going forwards. In terms of progress the last 5 years, I mean, I've been in social care, at least, been quite hampered by the ability to invest in preventative approaches. But we have, between the NHS and local authorities, we have invested in a lot of our relatively upstream prevention services like reablements or intermediate care services. Those have grown significantly over the past 5 years in terms of millions of pounds of investment, and they have actually shown a return in terms of the local authority, at least in terms of us being able to grow, to deal with relatively increasing demand, but with the same, roughly speaking, same cash budget over that 5-year period. So to me, that's a real success story. I lament the inability to invest further in prevention, as it were, that would take us further to prevent even more demand. That's the first thing. I think the second thing is, for the last couple of years, we've been focusing, haven't we, on primary care, community health and social work, working together in areas and in that regard working with community services as well, to take relatively experimental preventative approaches. Social prescribing is one. I'm sure you'll come on to that, but that kind of low level work has demonstrated a value actually, and I think that's been a real success as well. But other than those two specific areas, I think we've found a lack of resources for prevention. I think as we go forwards with the ICS, yes, it's a core strategic issue about how do we shift resources away from the higher end to the lower end.
Melanie?
Yeah, I mean, absolutely. I think I wanted to just come back to mental health again, actually, because I think this is one of the areas where we have got many fabulous voluntary sector organisations working in the domain of mental health for both adults and children and young people, and I think that's just been hugely helpful. It has made a big difference, enabling us to focus on prevention by having an early, more of an early intervention rather than waiting for crisis. Now, our model of care for people with mental illness is shifting, but too slowly. So I really, hope and planning for, because hope is not a good, you can't rely on hope when you're in a position like mine. You need to plan, not just hope. But I really am planning for having a model of care in mental health that focuses on much earlier intervention, which is a preventative measure than that prevents crisis. We need to do much better on this, and I think the work that has accelerated really over the last 12-18 months, particularly in partnership with the voluntary sector, has been hugely important. And I think just this last since March period, we've seen demand soar for in mental health, and particularly in young people and children. And I think the need for early intervention before crisis is even greater. We certainly haven't done enough, and I think that would be probably my biggest area today that I would want to focus on, really.
Great. I mean, that nicely pulls together kind of two of the questions that I've got here. So one around, I guess the design of some of the kind of the core pathways in both clinical pathways and adult social care, and the mental health piece is an example where it can feel like to a service user, I'm not ill enough to get support, which seems often like the antithesis of a kind of prevention-based approach. And I guess given that sort of system focused on prevention and thinking about some of those core pathways, what are the changes that kind of people and organizations are going to see on the ground over the next 12 months in terms of moving that tanker?
Do you want me to go?
Shall I go on, Melanie?
I'll start this one. There's a comment from Sally in the chat about the new investment. That's real. So the investment in mental health over the past few years, I know it doesn't feel like it, because it feels like at times we're chasing to keep up with the demand. But certainly the actual investment has risen dramatically for the last 3 years in Norfolk and Waveney for both adults and children. So that's important, and I hope it will continue to. And we're all anxious about how this big bill that there now is to be paid for is going to be funded and what's going to be prioritised. But I think without that protected investment, which I have no reason to believe won't remain and won't continue to increase, but I think that's going to really jeopardise everything if we don't continue to protect that. I think I am heartened by very much through actually this last period. We need to find a snappier time, because I never quite know how to refer to it. First wave since March, but hopefully you know what I mean. There have been just some amazingly new approaches developed, and that's very much come from people working together in teams, both locally. We've had lots of investment nationally, like I'm thinking about the new investment for the Freed model. I don't know if people have heard of that, for children with eating disorders and young people, which is absolutely before people get too ill. So it's early intervention. So there are lots of new models which are being rolled out. And I would really encourage and I would really encourage the voluntary sector, and would want the voluntary sector to continue to challenge and to continue to constructively challenge. We have quite a bit around that that's not constructive, and I'm not going to comment on that in the zone of mental health in Norfolk, but certainly please do continue to challenge, continue to push to give mental health the attention that it needs, and continue to push for a place at the table. And I would welcome you having a place at the table to co-design approaches, having the voice of young people, having the voice of parents, having the voice of the people that your organisations represent.
Great. James, any comments or thoughts?
Well, I think the only thing I would add is I think it's really good that the pandemic has sort of upended the NHS plan in a way and brought forward some of the investments in community responses. So our Aging Well programme, with 2-hour, 2-day response for older people. We've also got in the council a rapid acceleration really in housing as an alternative to residential care. So those trends will continue, I think. And then finally, I think we can't escape the fact that more investment will be needed by the council in the way that it supports carers. So I think those 3 areas, for example, those are trends that COVID has helped to accelerate, really. So I expect to see those to continue over the next 18 months or so.
Great. You would be surprised if I didn't talk about the voluntary sector, particularly in relation to prevention. But obviously one of the key areas of discussion over recent years has been the role of VCSE organisations, both in terms of some of the broad community wellbeing activities, but also some of the specialist preventative services, whether that's in areas of advice or support, and that role in that bigger systems piece. And from the questions and from the general conversation, it tends to throw up 3 kind of core challenges. The sort of demand and capacity planning piece, sort of making sure there's enough capacity to meet that demand, and that the capacity in the VCSE sector is kind of considered as part of that planning process. The integration piece, so the process of referral, the risk management, the data sharing, the kind of the safeguarding component of that, and importantly, the resourcing bit. How do we make sure that that demand, and it is very much about supporting that individual rather than organizations, is sustainably kind of resourced? So with those 3 kind of elements in mind, and thinking about that focus on that demand transfer to the VCSE sector, I guess, how do you see those challenges being resolved? And we'll kick off with James first.
Yeah, those are 3 hard questions, John, actually. So congratulations to the to the participants and the for those. I suppose if I start with the capacity and how do we bring that into the planning, it is really a challenge, isn't it? The further you are from something that's commissioned or contracted, the more difficult it is to conceptualize how to do that. I would say that in us having a joint commissioning approach between the council and the CCG, there is a degree to which stuff that we've contracted for, if I take Carers Matters Norfolk, for example, which is a capacity contract that we've let on behalf of both the systems, that we do take that into account as we try and plan our demand for the next year or for the next few years. Those existing commitments and the capacity they represent in terms of numbers of people that are supported, that goes into the planning mix, I think. It may not expand in the way that people might like, or it may change the emphasis of those services as we think about the new models that we're working with, but we do try to take those into account. I do accept, though, that there is a case for a discussion with the voluntary sector infrastructure about how do we support that sector to engage with us as we plan either the council's strategies or the health and wellbeing board strategy or the NHS sort of phases of work. And I don't have an immediate answer to that, but I acknowledge that we need to make sure that as sector leaders, you've got the ability to engage in the process of commissioning and planning. On the risk strat, I absolutely think there's an opportunity here. The shielding work has shown us that we have the names between us now of the 38,000 people in Norfolk who are vulnerable to some degree, either very extremely or just have a broader vulnerability. And as Melanie knows, before the pandemic, we were making progress on a population health type of approach and having those conversations. We haven't had the time to do justice to that work, really, as a result of the reactive way that we needed to operate in the last 6 months. But there ought to be an opportunity for risk strat work that is involving the sector. There are pockets of excellence, aren't there, in the west of Norfolk, the work there around Eclipse and the GPs there. So there are good examples that we can build from, but I absolutely think we need to do that. On the resources, as Melanie says, the NHS have had an investable strategy the last few years. The council unfortunately hasn't. That's not to bemoan that, but that's just the maths of it. So we've faced reductions of about 40 millions a year. In my case, in adults, about 25 millions of that. So we find it hard to expand the resources, but we do try to prioritise from the point of view of not cutting prevention that's going to cause us a problem next year. Although there will be some examples, I'm sure, where you think we haven't done that.
Melanie, over to you.
Sorry, just trying to unmute myself. And yeah, great questions. And I want to just say I am reading all the comments in the chat. There's some great comments. I can't see how, if there's a button to like any of the comments on Zoom, but if there was, I'd be liking them. So just on those two questions, I think it's a really, really fair challenge. And certainly we need to really reflect on this and just think about how we can engage the sector. I wonder if how the assembly that's formed might be able to help with this. I think one of the challenges, well, it's a challenge, maybe it's an excuse. One of the challenges, or one of the things that is said, let's say, about why the public sector doesn't always routinely engage with the VCSE is because there are so many different bits of it. Well, you could say the same about about the health and care sector, I'm sure. But I wonder if the assembly, the more the assembly can use its role, its leverage to be representative, I think that we should certainly look at that. As James has mentioned about money, we are. I know certainly the NHS in this first few months of the pandemic, the mood music was very different. It was quite unprecedented. I've never had to not live with a challenging financial control total, but this was certainly like, spend whatever it takes, save us, was kind of the rhetoric coming out. That dried up after about 2 to 3 months. Of course it would, wouldn't it? But I have to say it was quite bizarre, really, working in such a way, and liberating. But it has clearly, as you would expect, there are huge bills growing everywhere, and the financial regime within the public sector has changed completely on its head. And I think, it would be remiss of me not to say on this call, I'm really worried about the next 4 months of the funding allocation that we've been given. We've got a massive gap still in Norfolk and Waveney. We've got a £19 million gap for the next 4 months. And we are really fearful about what the funding settlement might be for 21-22, understandably, because of the economic position that the country's in. So against that backdrop, it's really important that the VCSE Assembly, I think, uses its role on the partnership board, uses that position with the Assembly, to execute its role as a full partner.
So you just taking that a bit further. One of the things that kind of came up in a number of the kind of questions was essentially what's often described as the perfect storm the VCSE is facing, in terms of kind of growing demand, a number of the issues that you guys have highlighted, at the same time as falling funding. So to give it a bit of context, both our local figures and sort of national percentage drops, it's about a 30% fall in income as a result of a range of kind of complicated issues around with COVID. In sort of Norfolk and Waveney terms, that translates to about 100 million in terms of a kind of a funding gap. And what we're starting to see is a pattern where it's medium-sized, prevention-orientated organisations, not necessarily in this year's budget, but come 1st of April, that seem to be most hard-pressed. And obviously, given the first part of our conversation, they're exactly the kind of the organisations that will be absolutely key to those strategic priorities. So I guess that's our critical kind of challenge that we're discussing as a sector. And I just want to invite your reflections, and I think I'll kick off with James this time, in terms of how, as system leaders, and that increased emphasis on a system approach within the ICS, how are we going to respond to that?
Yeah, I mean, that's really it's really challenging to think. Although is my signal still there?
Yeah, I can hear you fine, James.
Great. Oh, sorry, I just had a message say I was unstable. It's really challenging, isn't it? How do we do that? Recognize that there is a problem coming down the line, but at the same time act almost tactically in what we try to preserve. And there's a bit of a parallel here between the overall care market, in my experience, where some trends you're going to want to accelerate, and some others you don't want, but you therefore need to prioritize in response to the threats that you're facing. And then thirdly, I think there's a kind of campaign mode that I think you as a sector need to get into, to release some politics, to make sure that you get some priority, actually, because this is all about national decisions, isn't it, about what gets prioritized for funding. So there is a legitimate case for saying that we can't just rely upon the good nature of the third sector or the fundraising capabilities of the third sector if that fundraising is practically impinged upon by the overall recession or by the inability to trade in shops and all the rest of it. So there's something about the campaign mode which we can support, and we can get our councillors, in the case of the council, supporting as well. And then there's something about how do we, as a group of leaders, have the evidence before us about what needs prioritising, so that we don't allow very short-term decisions to take place that will impact on us in the medium or the long term. And then thirdly, there's something just about what could we work on together that might try and respond to that situation, together, facing the public and asking the public to respond, because one of the other lessons of COVID surely is people's response to this situation was extraordinary. The discretionary effort and the money that they put into a response themselves. I think whilst you can't substitute that for the whole of that 100 million, we might be able to do something together that tries to make a response. So those, I think, will be my three responses to that.
And Melanie?
Yeah, I think that's a great response, James. I really like what you said about getting into the campaigning mode. I mean, there are a number more restrictions on what public sector can do, can say potentially. And I said earlier, I'd really welcome you pushing into and taking the stage, and also campaigning around this. These are national decisions, a lot of it. So I certainly would. I think that's an excellent point. Yeah.
Okay, great. Thank you. So we're shifting tack slightly in terms of a conversation around kind of equalities, which is kind of been a big sort of discussion throughout COVID, and I guess around kind of two sets of issues. That kind of disparity in outcomes for different members of our communities, whether we're talking about kind of ethnicity or sort of broadly deprivation, and also the treatment of people by institutions, particularly thinking about the Black Lives Matters movement, and whether we have sufficient diversity, particularly within decision making within organisations. So the kind of opening kind of question within that, and Melanie, I'll start with you, is how are you responding to both those agendas?
In terms of how are we responding in terms of the agenda? Can you just say what the question again?
So I guess, yeah, so your response both in terms of that kind of disparity of outcomes piece, so that the inequality around health outcomes, but also I guess that broad inclusion piece, picking up around the treatment of different groups in our society, and sort of diversity of leadership and diversity of voice across our organisations.
Yeah, no, yeah, absolutely. It's an excellent point. I mean, well, there are multiple ways that we're engaging it with this issue around, you know, fundamentally racism has been at the heart of a lot of the health inequalities, and certainly starting with, if I just call out some of the areas that I think as a service we've been reflecting on since and taking action on over the last since March, starting with our staff actually, you know, starting with NHS staff who are from, and this will be different in different sectors, but staff who are from a Black, Asian, minority ethnic background have fared less well, have had you know, have more people from those communities have developed COVID, have had poorer health outcomes. So starting with our staff, actually, even just making sure that we are doing more to protect those staff from health that are at an unequal health status compared to the rest of the population. So there's a whole series of work and attention being given there. I think then thinking about our communities and our most vulnerable, we are actually, James, you mentioned population health management earlier, and I'm really proud of that's one of the things I'm really proud of, how we've accelerated risk stratification using data, looking at data to inform us of the most vulnerable in society and targeting interventions to those. And so, for example, James talked about the clinically most vulnerable. Well, we have used data to identify the clinically, not those who are shielded, but that was clinically extremely vulnerable, but those that are in need, and integrating social care support and voluntary sector support with those most vulnerable using a tool called, started off being called COVID Protect, now it's called Protect Norfolk and Waveney. So certainly that's one area where I'm really pleased about our approach to health inequalities. What I would like to have done more of, and what I would still like to do, because we haven't, you know, we're still very much in this and learning all the time and wanting to improve, is I think just having direct conversations with communities as well is an area that within the NHS we've reflected on. How can we do that better so that we are hearing from people directly and from community groups that are most disadvantaged? I know in some parts of Norfolk this has happened, and voluntary sector have helped facilitate those open conversations, but I would like to do more of that. I mean, certainly that's one of the things I said in my opening remarks, I think, about when you posed those first few questions, John, about what am I proud of? What I'm proud of is how we responded, but also really acknowledge then what I'm now worried about, the health inequalities and that we need to learn, and we are learning from and thinking back to what we didn't do well in that first wave and trying to ensure that we don't make those same mistakes and that we do better in this next period. So especially as, you know, the impact of the economic impact has been just so devastating.
James, your thoughts on those issues?
Yeah, first of all, in terms of the diversity and the representation issue about the decisions that get made, no, I don't think we have got that right. And after during our debates in the county council about Black Lives Matter, we released a huge amount of internal discussion, actually, which just illuminated a different Norfolk that you don't normally see from our Black staff about how they felt, how it feels to work in Norfolk, and the discrimination that people face. I went to a fantastic meeting hosted by the Dean at the Cathedral, talking about what it's like to be Black or Black and minority ethnic person living here and the experience. And it was really shocking, actually, and a bit humbling that you see yourself as progressive, or you see your community as progressive, but actually for some people it isn't. So I think we've tried to learn from that and incorporate some of that leadership now into our arrangements in the council, and we've started off a process of training, actually, for our councillors and for our senior leaders to get that debate going. On the inequality side, though, like Melanie, I've seen some brilliant evidence. The NHS are so much further ahead, actually, than the rest of us in having those debates and targeting the evidence. And I've been to a couple of really excellent discussions at local delivery groups where we put up the evidence about the outcomes. What we can't expect, though, is the health service to tackle this problem on its own, because a lot of the discrimination is about the wider determinants of health, jobs and housing and position and power in society. So you can't, you've got to be realistic about that. The other thing that I think we need to do is to respond in some very specific targeted areas. So for example, the work that we've done on asylum seekers or on refugees, those show us what power we do have, where we do intervene, and we can make a real difference, actually. But it has to be structured, and we'll have to go at this for some years. We can't just do it once, actually.
Just to pick up on that sort of diversity and internal organisation piece, I think one of the things we're struggling as charities is around leadership diversity, particularly kind of given Norfolk's demographics and particularly kind of board diversity around trustee recruitment. And one of the kind of questions that kind of came through was around elected members, and I pulled this up. If you look at the county council elected members, they are apparently all white. They're 77% male, and they tend to be from an older demographic. And I just wanted to what extent do you think that's a problem, and how do we go about kind of addressing it if it is?
Yeah, I mean, it's definitely an issue. I wouldn't call it a problem. It would be rude of me as an officer to say that as politics has a problem, but it's definitely an issue. And of course, it's inherently political. So the political parties have got to do a job of making sure that they aren't sexist and aren't racist or exclusionary to people in their own local politics. And you've kind of got to get that. That is not necessarily a short-term fix for our politicians. But there are some things you can do in, as a response to that. You can do some reverse mentoring so that you get some input into the political leadership so that people can understand the impact of what it's like to live in Norfolk or to be political but excluded. You can also do some training around unconscious bias, for example, so that you can try to compensate for some of the impact of that. But the ultimate message really is to the community, isn't it, to get involved in politics and start your own party if you can't get into that one. That's the kind of response that ultimately you need. I mean, when you look at other parts of the country, you do see that happening, and I'm sure it will happen. It will come to Norfolk, but it's incumbent on all of us, I suppose, to take part in it.
If I could maybe comment on that, John. I know the question was about elected members, but and was about diversity, and I'm glad we touched on gender in that answer as well, because actually diversity of gender is equal. It's quite disarming, and as a very senior woman, I know I have to work twice as hard when I'm in groups with elected members who are generally older white men, So I think I wouldn't describe it as a problem, but I would describe it as something which can at times be quite disarming, and it's an issue. And I would love for people to become more involved in politics. And yeah, I think I think actually continuing to talk about it, John, actually to call it out and to focus on it is really important, because I don't think necessarily in all of the groups that we've just mentioned, there is that focus. It almost comes across, this is the norm, this is how it is. And that's not okay, because some of the, I better stop there. And I know I've got to leave at 3, but probably I better not say any more than I've already said on that.
So aware of you for free. So I will focus these 2 questions on you, and then allow you to disappear off. So just picking up on that qualities bit, there was a section around staff experience, and again I looked up, and if you look at the NNN staff survey for 2019, you got 37% of people saying they experienced discrimination on the basis of their ethnic background. And I have to sort of say that's actually below the benchmark for the group average. So performing better, but still a huge percentage of people experiencing that. You obviously have in health a range of frameworks to kind of support that. The one I've had some experience of is EDS2, a quality delivery system too. But there's this sense that sometimes they're kind of treated as a kind of a governance compliance tick box type exercise. And I just wondered, how do we avoid that being a kind of tick box exercise going forwards?
I think, John, that actually I think that's again one of the really positive conversations and focuses that we've had since March, in that actually a real support, calling out and focus on needing to support people from Black, Asian, minority ethnic groups, particularly, and diversity. And certainly I've worked in the NHS for over 20 years now, and I've never experienced such a time as I had like these last 6 months, where there's actually been intent and action and focus. I mean, it's gonna need continued attention and action, of course, but I think I can, certainly speaking personally, and I expect some of my colleagues would probably say the same, our level of understanding, our focus, and the tools we have at our disposal to help and to support and make things better can't change the world, but actually we can make working conditions safe and psychologically safe in the first instance for people. And I think there's been, I think that's been really a positive thing to come from the last 6 months. We are given a lot of support, a lot of tools, and a lot of techniques, and it's incumbent on everybody to make full use of it. And the NHS, being the NHS, is a big, making sure everybody is. So put it like that.
And the final question to you, because I know you have to kind of go. You touched on it earlier about the huge effort that our workforce, across all sectors has put in, and how challenging that's been in terms of the hours and the ability to kind of sustain that. So just as a sector, a leader in that space, what's helped sustain you most over the last kind of 9 months, and what would you share to other leaders?
Well, yeah, great question. What's helped sustain? Yeah, I mean, certainly I've felt very privileged at times when, I constantly remind myself about how I feel privileged to have a job. I feel privileged to have a job that I think is making, I hope is meaningful at the moment as well. And I'm never forget that. I think as well, what sustained me is just keeping things really simple. Actually, one of the things that I've enjoyed during this last, if I can call it enjoy, probably the wrong word, but one of the things that I've reflected on and think it's made a difference is just trying to keep my life as simple as possible, and really enjoying some routine and simplicity. I'm fortunate to have family and green open spaces that I can move into. We're allotment holders, so spending time on my allotment and not doing half the things that I used to do that I thought were sustaining me, and probably I won't ever again.
Great. First, James, I will give you an answer to that, and maybe if you've got some minutes, probe you with a couple more questions on the list, because we had a lot submitted. But Melanie, I know you have another commitment, so I just want to say thank you very much for your presentation and contribution, and for answering those questions.
Okay, thank you very much for inviting me, and thanks very much, everybody. Nice to meet you all.
Thank you.
Thank you.
Bye.
So James, I guess same question for you, if I may. What's helped sustain you as a leader, thinking around that workforce piece?
Yeah, it has been a challenging period, actually, and I have written elsewhere actually about the 6-month wall and the impact of that. And there's an author called Aisha Ahmed, who works in international disasters, and she's been tweeting and writing about this stuff, about what happens in any kind of emergency. And once you hit 6 months, you kind of have a real fatigue moment. And so some of the things that she wrote about, actually, I've found really useful to think through. So it's about trying to look after your own mental health and physical health where you can, although I have put on a few lockdown kilos, it has to be said. But trying to take some what she calls shore leave. If you can't take annual leave, and we haven't really been able to do that because of the impact of the constant working, and I've had a national role as well as a Norfolk role, but you can take shore leave. Actually, you can switch off, switch the social media off, go watch a box set or whatever, something that rejuvenates your brain, or read a novel. And so there's some of that. And the third thing I'd point to is what Melanie discussed as well, which is taking pride in how social care workers particularly have responded. We do have the badge, and I just think that social care out there in the distributed nature of workforce that I work alongside in the various care homes and whatnot, they've been magnificent. And you've always got some examples in those stories to draw on about real positives, things that people have done or experiences they've had. Very sadly, the many deaths, the many sacrifices, and the bravery, awful as that is, it can be a source of strength as well, in terms of your own resilience.
Mm-hmm. One of the things that's been very pleasing to see across the system in really the last 12-18 months is a kind of a conversation around workforce that's very inclusive of not only kind of NHS colleagues, but increasingly social care colleagues, and increasingly VCSE, but also groups like unpaid carers and volunteers. You talked about unpaid carers earlier, and we had a specific question, which was, how do we build on the momentum of things like the Carers Charter? How do we make sure that we kind of move forward to make sure that kind of carers are being identified and supported?
Yeah, I mean, we definitely need to, at a very practical level, make sure that we in the council and the NHS alongside us proactively reach out to family carers, so that we understand both where the risks are of the work that they're doing and the impact on their health, but also so that we can target some more resources into that situation. So some of the COVID monies that we've received from government, we've tried to plough into doing that. And I think we need to continue to do that over this winter. In my national role in ADAS, we've called for £1 billion to be invested into family carers, to give every family carer 50 quid a week for the 20 weeks of winter. I have no idea whether Rishi Sunak will have seen that, or whether he'll be able to listen to that, or will listen to that. But it's that kind of response that's needed, actually, to sustain family carers, I think, over the next 6 months. Otherwise, we could find ourselves in a really difficult position. So that's the first thing I'd say. And then the second thing, I think, is for us to practically, as it were, find a way of having carers feed back to us and let us know, what changes need to take place to work differently with them. There must be an opportunity of learning, like we have with discharges or like we have with some of the other initiatives around housing. There must be something to be learned actually from family carers about what's worked during this pandemic and how they've coped.
Right. And so the other part was around the role of volunteers. We saw a huge number of people step up in their communities to volunteer. Incredibly positive and incredibly significant kind of contribution to our overall effort. We're also seeing, a range of more services, whether it's primary care, whether it's hospitals, whether it's out of social care, look to use volunteers as part of their kind of delivery mix. And some conversations in the sector about recognizing, volunteers are not free, recognizing there are limits, volunteers are not about an on-demand workforce. Melanie mentioned the COVID vaccine, and I got an email about wanting to recruit 30,000 new volunteers to support that vaccination program, a huge ask. What's your thoughts on the role of volunteers as we kind of move forward, and how do we guard against essentially the conversation that's had of maximising the role of volunteers, maximising that positive contribution, but avoiding us exploiting an unpaid labour force?
Yeah, it's a really difficult balance to get right, that, it seems to me. First of all, we have to get the ask right. So right at the beginning of COVID-19, we had a call for volunteers, didn't we, through the NHS, and a really brilliant response to that, but almost no task defined, actually, from my perspective. And I think it was a real mistake to, as it were, march everyone up the hill to find that we weren't quite sure whether we're going to go down again or not. So something about just being really clear what we want volunteers to do. And this vaccination call is a case in point, isn't it? Let's be really, it'd be great to use volunteers, but we just need to understand, is that going to be resourced? What exactly is it that we need people to do in terms of marshalling and getting ourselves organised? So that's the first thing. I think the second thing is plain old resources. So if we are going to, if we're going to sustain volunteering, we've got to be able to resource it as a society. And I'm afraid that goes back to that question about what is going to be the position of the NHS and of local authorities in terms of being able to put more capacity into volunteering. I don't think any of us as leaders want to substitute paid work for volunteering for reasons of training and development, for reasons of risk, and for ethical reasons, really. We don't want to, as it were, degrade jobs. Not saying volunteers aren't equal in their value, but it would be wrong of us, I think, to substitute one for the other. So we definitely don't want to pursue that line, but we do and will have been reminded in the last 6 months about the power of volunteering, just as an individual, as well as dealing with emergencies. I've been a volunteer too over the last 6 to 9 months, getting shopping, delivering things, using WhatsApp groups. So that you want to promote, but you don't want to exploit. And I think part of that is just about your ethics and making sure that that doesn't become the dominant mindset, even if it's expedient. It's not right to do it.
I certainly echo your thoughts around a very clear volunteering ask. And I think we're a lot stronger locally with Work of Voluntary Norfolk and with our local council colleagues in terms of getting that right. I think one of the things I'm always keen to kind of balance around that volunteering conversation is actually the fact that we had more people coming forward in our communities than we had need for them to support. I think is actually a really positive statement about our communities, as much as it was a challenging thing at times for us to kind of manage. We got a sort of a set of questions that's really around making sure we put people at the heart of our service design and people in control of their kind of care. And there was some concern kind of expressed that throughout first wave of COVID, some of that service user voice, some of that service user experience was put a little bit on the back burner. And there's kind of some concerns going forward that some of the new structures, particularly primary care networks, led by private sector kind of GPs, there aren't enough safeguards in place to make sure that that user focus piece is central. So I guess the question is sort of how do we make sure we can kind of continue to kind of create models of care that enable that kind of absolute focus on the service user at the center? I can't quite tell if you've frozen, James. Oh, I think you're back.
I missed the last part of that question, John, but I think it was about how do we make sure that co-production remains at the heart of how we design services?
Service users at the heart, yes.
Yeah,
yes.
Okay. Was some of this is about making sure we build on the existing structures we've got, like making it real group or the disability advocacy groups, and ensuring that those people have an ability to engage in the planning discussions or the commissioning discussions that we've got. I certainly feel that in terms of primary care and the local delivery of primary care, that we really must insist that community groups and either patient groups or service user groups are actually present in those meetings, so that we remember that mindset and then we can start actual engagement at that level. I think what's been helpful around the response to COVID actually has been, even though we suspended choice, as it were, around discharges, and even though we had the potential to ease the Care Act, to freeze the Care Act, actually in Norfolk and Waveney, we didn't do that. We kept that representation going, and to some degree, we might have strengthened even some of our guidance and working around, for example, people with direct payments, to be clearer about the flexibilities and be clearer about the rights that they have. So I feel quite heartened in a way that although that risk was there, actually our response wasn't to have taken choices away completely, but I have to recognise that in practice, care situations have become rather closed, so people's choice about whether they do or don't attend them was taken away from them for the purposes of public health, and people's choices about being discharged were very much trammelled by the urgent need to take hospital occupancy down, and that must have been quite difficult, and we're still working through the consequences of that. So I don't think that, I'm not making light of those changes, they were real, but I like to think actually this collective experience has probably strengthened co-production. What I think is key though is that we're honest about what changes it can and can't lead to. There's no point pretending that we can magic up resources as a result of co-production, but we can at least talk about the limitations and try to be relatively straightforward about that.
And that sort of adult dialogue we've talked about before. You mentioned direct payments. One of the questions we had was around the role of personal budgets, and obviously in adult social care, personal budgets have been around for a longer kind of period, and we're sort of starting to see kind of increased use around health. And I guess there were kind of two questions. So one is, where do you see that the role of kind of personal budgets kind of moving and developing? And the other is Melanie touched on with the ICS framework, the kind of the budget integration model being built around kind of place, that we kind of pool an idea at kind of system, at the kind of place and at neighborhood to kind of get that more integrated working. And the other approach to that is that you pull around the person, and that's that space where that kind of personal budget kind of exists. And I'm interested in, firstly, your thoughts around the kind of role of personal budgets in general, and then kind of secondly, your kind of reflection on those two approaches of whether, in order to get that integration piece, which we're all committed to making sure works, we kind of pull more around the person or more around the place.
Yeah, I mean, I'm a big fan of personal budgets and personalisation. I manage a personal budget myself, actually, for my sister who has learning disabilities. So this is a different council in Wokingham, but so I've got experience of actually the power that gives to a dynamic and a situation, and using a payment card and taking control. So I'm absolutely up for continuing personal budgets and expanding them. I suppose in social care reform, when it does come, I expect to be at the heart of it a rejuvenation of that. I'd like to think that the original vision of people won't recall this, but back in the day, we had individual budgets which combined the social care element, the housing element, the education element, and the health element in one. And you could have all of that as an individual budget. We never quite got there because the technology wasn't quite right, and the politics of getting all of that decided through different public bodies wasn't right. I'd like to think now, 5 years on, there is prospect actually for that sort of pooling around the person type of arrangement taking place, because we have got the kit now. You think about the technology and how it's moved in the last 5 years, and the notion of an account holder and being able to log into your PB and manage it through an account, much more doable nowadays. So I'd be up for Norfolk trying out some of that cutting edge innovation in that regard. But to come to your other question about place, I think it's absolutely essential, and I'm sure Melanie won't mind me saying this in her absence, but to have the NHS really focus now on place rather than on body parts or particular pathways is really, really positive. And they've kept at this now for a couple of years in the NHS plan. So I do believe that we have the prospect of really taking an area-based approach between healthcare and housing and community that we should absolutely take advantage of and try to get as much resources devolved down to a place as we can, but not devolving things that actually you'd want to have managed once right across the system, like a PB service. There's no point really having lots of different ways of doing that. You might as well do that once. But I am a fan of, I suppose, having my cake and eat it, working around particular communities, autism, for example, or sensory disability, but also working in place to bring community resources to try and deal with the inequalities, say.
So you mentioned it there, that kind of shift within NHS institutions to kind of focusing on place, and there's often a perception that particularly in the NHS there's a very distinct pecking order with acute care at the top, and I think we all kind of come up with our distinct orderings of where we sit kind of below that, but that place piece requires kind of quite a significant kind of cultural shift. And I guess, and it's a shame we've lost Melanie for this kind of conversation, but I'm interested in your reflections on how far along the journey are we in sort of delivering that kind of cultural shift?
I suppose Melanie might say that part of the whole ICS creation is to try and achieve integration within the health service in a way, because that internal market for the NHS, the whole Lansley reforms, were very fracturing of organisation. So the acute hospital had its own dynamic and its own incentives. Community health, a different one, primary care, a different one, mental health, a different one again. This ICS notion is actually bringing together strategic commissioners and providers to collaborate. And that collaborative culture, I suppose, is now what is being promoted by an ICS. And it allows the CCG to just give some outcomes to providers in an area and say, can you get on with achieving those outcomes in a very different way than a simple contractual transactional relationship. And I think that carries with it the risk of the hospital dominating, not suggesting it's going to be easy to shift that power away. And certainly if you vertically integrate a hospital and community services, you've always got the danger of one particular model dominating. But the fact that GPs and primary care networks have had definite investment over the past couple of years and will have further investment in the NHS plan means that there is a bit of a counterweight. But you in the community and we in community services will have to really drag that so that it doesn't become dominated by the hospital agenda which frankly we all love as a community, don't we? We love a big hospital, we love a good old car park to go and park in. You know, we are part of the cause as well as the solution, it seems to me. I think our leaders, though, in Norfolk and Waveney, Sam Higginson, for example, at the NNN, they are committed to community work. They do see the point that if they don't get the community working effectively, then they can't really do their jobs. The hospital, the system becomes snarled up with problems because we're not being preventative. So I'm an optimist in that regard.
Great. I'm conscious of time, so this will be the kind of the final question, and I also just sort of give the floor to you for any kind of closing thoughts. We had a number of questions that was really about kind of expanding different kind of services in the community, whether that was kind of so green infrastructure services, whether that was social prescribing, whether that was arts-based therapy, and sort of the role for that kind of going forwards. So I guess my question in that is, what are the sort of solutions that you want to see more of in communities? And I guess, how do we make sure that we have that vibrant market mix around VCSE providers, around small contractors, as well as, you know, the acute and that kind of space?
Yeah. So my professional association, ADAS, the Association of Directors of Adult Social Services, published 9 statements in the summer, which were all about what do we want from reform, where do we want to go, and the kind of things at the heart of that, I suppose, are what I would like to promote locally. So every care decision is a housing decision. So we've got to focus on what are people's housing situations, what's the housing support that people need, including rough sleeping and homelessness, but going up to how can you make the house technologically able to give a response to your needs. So things like that, I think, could be quite innovative and just fundamentally change the way we're working by the use of technology. In the care markets, I would like to see a fundamental review, actually. I mean, Melanie talks about sexism. Social care is largely a female workforce, underpaid, undervalued, not given a great deal of collective rights. I would be really keen for collective rights and for care workers to kind of come together, to campaign together, and I'd like to see wages at £10.90, which is a band 3 nurse or nursing assistant, sorry. You know, so there's a parity there. I'd really, you know, to do that though would bankrupt the council. So we've got to get the funding regime right in support of that. So housing and the care markets, and the third thing I would say is a social justice agenda. So the people on the margins of our community in Norfolk, prisoners, asylum seekers, refugees, people with mental health problems, people excluded because of disability. That's where I think some of our work has got to now concentrate going forwards. If we just do the same old, then we'll function, but we won't deal with those inequalities unless we tackle those areas.
Great. Before I wrap up, are there any final kind of thoughts or reflections you'd like to give?
Well, I end where I began, really, acknowledging the value of the VCS and not underplaying the power of the VCS as a voice for Norfolk. I suppose we've got to find a way together to make sure that as we do integration, that voice isn't lost, actually, and it's given a structured place around the table. So it's there at the partnership board, but through that assembly, it can amplify what needs to get said on behalf of the community. And thirdly, in my regard, in the council, that it can connect itself to the politics of Norfolk. So that what I'm not suggesting volunteer to become political, but politicians understand that value as well. And I think those 3 things are really, really essential. So all credit to the response, but much more to do going forward, and look forward to doing it alongside you.
Definitely. Well, James, thank you very much for your time, and thanks again to Melanie. We very much appreciate that. That's quite a large chunk of your day. Thank you for everyone also spending time. Great comments in the chat, listening in. Apologies if we didn't manage to kind of get through to your questions. We did have quite a lot submitted, and we sort of tried to compile them together, but I hope you found that a interesting and stimulating session, and a positive note to end on in terms of certainly a huge contribution made, but a huge contribution still to make. And I equally look very much forward to working with you across the sectors in terms of pushing forwards. So thank you for your time and enjoy the rest of your days.